Hello, everyone. Welcome. My name is Karen Lee, and I would like to welcome you to the California Improvement Network, or CIN, webinar titled The Triple Aim, Improving Health, Optimizing Care Experience, and Reducing Costs. Just a bit about the CIN. It is a partnership between the California Healthcare Foundation and 8 partner organizations around the state to support the spread of improvements in chronic disease care. We host these monthly webinars on timely topics related to improving clinical quality, patient experience of care, and or reducing the cost of care. And as you can tell from this webinar, we'll address all three. Since there are many people joining the webinar, everyone has been muted. If you would like to ask a question, please send me your questions through the chat function, which is to the lower right of your screen. We have planned for there to be about 20 minutes of Q&A after the presentation. So first Carol will speak, and then Ellie and Barbara will follow, and then we'll take questions after that. I'm pleased to present to you our speakers today, Carol Beasley, Ellie Littman, and Dr. Barbara Paula. Carol is the Director of Strategic Projects for the Institute for Healthcare Improvement and has overseen numerous projects, including health information systems in primary care and the triple aim of improving population health and individuals' experience of health care while stabilizing or reducing per capita costs. Ellie Littman is the Executive Director of the Health Improvement Partnership, a cross-sector coalition of healthcare providers in Santa Cruz County. Her career has included quality improvement work in home health, hospice, chronic disease management, and inpatient care. Ellie is a fellow of the CHCS Healthcare Leadership Program. Barbara Paula serves as a physician consultant for the Health Improvement Partnership of Santa Cruz County. Before this, she was the medical director of the Central California Alliance for Health, and prior to this, the Santa Clara Family Health Plan. She was also Chief of Ambulatory Pediatrics at Santa Clara Valley Medical Center, and she is also a fellow of the CHCS Healthcare Leadership Program. So without further ado, I will turn it over to Carol.
Great. Well, thank you so much. Can you hear me all right? Just want to make sure that people can hear me, so somebody give me a little sign. Karen, can you hear me?
Okay, I can hear you well.
Okay,
yeah.
Good. I just wanted to double check that. Thank you. Well, thank you so much for inviting us to be a part of it. And it's actually a special treat to be on with Ellie and her team as active AAA partners who really can give you the full flavor and texture of what this work is all about. But what I will try to do is at least set us up and provide some framing within which we can start to talk about particular examples, whether they're your own examples or the example, for instance, of the folks in Santa Cruz County. So the triple aim is really the simultaneous focus on 3 aims that don't necessarily run together. They have the potential to pull against each other, but it was a response from IHI to the challenge of trying to make whole system change real, and a challenge to ourselves to get out of particular silos of care or particular conditions and start to look more ambitiously at the system as a whole. So the aims that you can see summarized here, we've talked about them a couple of times, are actually improving population health, improving experience of care, which is more than just did you like it. We include all of the quality dimensions into that experience. Was it safe? Was it accessible? And all of the things that we would want care to be for individuals. And finally, can we get a handle on per capita cost? We know that in our country we spend something close to twice as much as everybody else in the developed world, and we don't get the sorts of results that we're really interested in. So we also, the triple aim forces us to recognize that health care is not the most powerful lever we have around health. So it pushes us outside the edges of the healthcare delivery system, which is traditionally where we've devoted most of our attention, and forces us to consider things like the contribution of behavior, the contribution of social circumstances, and all the rest of it, if we're really going to be serious about improving health. We have quite a number of partners in this work. This work is about 3 years old. We started it in 2007 with just about a dozen sites, and we now have 6 dozen sites. We have over 70 sites, not just in the U.S. and Canada, but in several countries around the world. And this slide is detailed. I'm not going to go through it all, except to point out the diversity of the kinds of sites that are at the table. So everything from health plans to government agencies to employers to social service agencies, along with delivery systems and the usual players that we're often in partnership with. So it certainly has enriched the work immeasurably. This is our list of international teams. You'll see that it really clusters up and concentrates in the National Health System in England, though we also have participation from Scotland, Northern Ireland, Sweden, Singapore, Australia, and New Zealand. So I'm saying recently that the sun never sets on the Triple Aim. We are focused on the 3 aims, and in typical IHI fashion, we have a set of measures that we are working towards. And I should say that this work for us really falls into the category of prototyping or innovation. It's relatively early stage work. It's very large system change. And so the changes that we're making and the measures that we're using are a bit provisional. We have articulated some theory, which I'll share with you in a moment. And these measures are a bit aspirational, but I will tell you that all of the sites that are on the list that I just showed you are committed to working at a population level, not necessarily the entire population they serve, but some meaningful subset of that population. And they're committed to both results and measurement in all 3 of the dimensions of the Triple Aim. So it's not always possible, for example, for every organization that's participating in this to have a robust measure of health or functional status. Some of them do and some of them don't. But all of the sites do have a measure that they can use and that they can learn from and that's meaningful for their population in the area of population health. Similarly with patient experience and similarly with per capita cost. So to be a participant in this work means that you are committed to all 3 aims for a population and that you're committed to measuring around the 3 areas and that you're an organization that will get value out of collaborative learning and acceleration from working with others on this. I'll say a little bit about measurement that because we're looking at huge system change, we really have to contend with the fact that it's going to take some systems of measurement to wrap our arms around it. The most successful sites that are using the Triple Aim, I would say, are using it as a framework within which to locate many different strategic initiatives that together will produce the kinds of results that you would see in number 4 on that list. To see a positive trend in terms of something like per member per month total cost. But in order to get to that whole system result, there will be layers of measurement. Some of it perhaps very exploratory as we start to understand what might be some changes we could make that would shift costs. Starting to develop some practical measures across all of the domains and then integrating from the project level to the subpopulation level to the whole population level, starting to roll up individual initiatives and both the process and outcome measures associated with individual initiatives into a large whole system result. This is an example actually from one of the sites that has been with us since the beginning, Care Oregon, which is a Medicaid managed care program in the state of Oregon, and this is how they've started to depict some of their systems of measurement. So this one relates to cost, and you'll see in the sort of horizontal segments. Actually, maybe I'll set an arrow down here. Each of these rows describes an area of focus and some metrics, and then for each of those metrics, they have projects, and then within each project, they have metrics. So you'll start to see the relationship amongst the measures, where each one sort of drives the other into a full system of measures that will get them towards one of their major aims, which is to stabilize or reduce their per capita costs. The collaborative itself has been going, as I said, for about 3 years now, and we have been through several phases. We actually work in 9-month cycles. We started simply by kind of testing and validating the concept design to see if it made any sense. This is kind of early work, as I said, and we wanted to see if the theory could stand up to scrutiny. Second time around, we started to get into some detailed designs of some of the components of the concept design. In the third phase, we always build on the prior phases, so we added in the dimension of designing for large subpopulations like children or adults of working age or adults over 65 or individuals with a high level of medical and social complexity. So we're talking about very, very broad population definitions. We tend not to, we've found it just a little bit less useful to look narrowly at clinically defined populations. We tend to choose broader categories or classifications than that. And right now we're in phase 4 and starting to really expand our focus to not just subpopulations, but really starting to think about how we could have an impact on cost, quality, and health in an entire region or community. So I wanted to share with you just a few snapshots of some of the work that's been going on in this community by some of the sites that we've been working with to give you an idea of how the sites are describing their work, what are some of the measures that they're using. So this first example comes from Bellin, which is a integrated delivery system in Green Bay, Wisconsin. And the population that they chose to start with was their own employees. So they started, and this is actually not a bad place to start. A number of our participating organizations have started there. These are individuals that they know. They have a close relationship with them. Many organizations are self-insured, so it's a very relevant issue what they're spending to provide care and health insurance to their employees, and they have access to these people so they can try out new designs. So what Bellin is depicting here is what's happening in those pink bars to their per capita cost relative to some benchmarks in their geographic region. So you'll notice that they started out on the high side compared with their peers, and they're now about 20% below their peer group. On the other axis, they're looking at their health risk assessment scores, and Bellin is an organization that's done quite a lot to understand the health of their population by using systematic health risk assessment methods. So you'll see that as they were able to bring their per capita costs down, at least relative to some comparator organizations, they were also able to push their health risk, they were able to improve the health risk profiles of their employees. This is another participant, Genesis, another integrated delivery system also in the Midwest in Flint, Michigan. And they have the population that they were focusing on for this piece of work is the uninsured individuals in their county. So they started to partner up on a county-wide insurance program for otherwise uninsured individuals. And again, they're trying to, you'll see that the sites are starting to assemble at least the beginning of some depictions of results in all 3 dimensions of the triple aim. So their proxy for per capita cost was emergency department use per 100 measures, or per 100 members. So they figured that ER use probably drives a lot of cost, so they wanted that rate of use to come down, which it has. They're looking at patient satisfaction, which started high and has remained high. You can't get too much higher than 99%. And they're looking also on the health dimension at to what extent they're able to encourage their members to adopt and maintain healthier behaviors. So again, their measures look a little different than Bellin, but they are holding themselves to account for progress and for measurement on all 3 dimensions of the triple aim for a population, in this case, previously uninsured individuals in their county. This is a depiction of, this is actually the first dashboard that we saw that had all 3 dimensions on it at once. It comes from Health Partners, which is an integrated system in Minnesota. So they both offer care and they offer health plans. And again, they have represented outcomes that relate in some fashion to all three of the aims. The red line going up and to the right is the percent of their patients with optimal diabetes control. Again, that's their proxy for health. Doesn't maybe get at their whole population, but it's a start. The green line shows their per capita cost compared with statewide averages, which you can see is going down. And their measure of experience is whether their members would recommend their services to others. So we could argue that each of these measures could be improved, and I think that the folks at Health Partners would certainly agree with that. But the challenge of getting to this point of being able and willing to hold oneself accountable for results on all three dimensions is, I would say, quite a breakthrough for an organization to make. And then I think I'll wrap up the examples with this one, which comes from a business, Quad Graphics, which started their own healthcare services within the organization. They were not satisfied with what they could purchase on the open market, so they actually decided to build their own system. And they have pretty good data over time on their per capita cost, again, comparable with other health plans in the Midwest. And then for the experience measure, they utilized a couple of questions from the How's Your Health questionnaire that John Wasson and his colleagues at Dartmouth created. And they've actually distinguished the part of their population that has a greater disease burden from that which has little or no disease burden. And they're mostly concerned to see they want to see progress in both, but they're particularly attentive to seeing improvement from among their employees, who are also their patients, who actually have health needs, who have some level of disease burden. They've also, in terms of their experience of care, they're also tracking the degree to which they're using evidence-based practice. So they're benchmarking themselves against some national measures and starting to roll up some of those areas of their clinical performance as one or as important dimensions of the patient experience. So I'm going to step back for a minute from those examples and talk a little bit about and I know I just have a few minutes left, I'm watching the time, talk a little bit about how the work of the Triple Aim gets done. While there is a framework that we use for making improvement, the Triple Aim, I think, at its heart is a learning system. So I've talked a little bit about some components of that. We've talked about system-level measures. I didn't spend a lot of time talking about the theory, but we do have an explicit theory and some concept design that we're testing to at least put some order around how we're doing the learning. We're committed to segmenting the population. We think if you're going to work on population health, you're going to have to group it in ways that make sense and address the needs of segments of the population that are distinct. A lot of what we're doing is founded and grounded in good improvement science and good improvement practices. So all of the PDSA and improvement technology that we use in many, many different kinds of environments and challenges are certainly there's a premium on good improvement methods here. We've done a lot with informative cases, so sometimes when we get stuck around good design ideas, the way to get unstuck is actually look at an individual case, and we've had some wonderful breakthroughs in our perspective about things when the teams have literally just looked at a case and extracted learning from it. We're starting to get to the point where we can do some scaling up and spreading of good ideas, and periodic review is a very big piece of what we do. This is just to re-ground you on the sequence that this collaborative has gone through in its development. I'll just leave you with a little bit of a view of the future. We, I think, know that for the most part we operate in a pretty low-value system. This is one way to depict the drivers of low value. Low value could be seen as a product of high cost and low quality. And we're starting to think about how we might actually reverse that at a regional level. So this probably deserves a bit more time, and you may want to study this a bit more at your leisure. But this is a set of ideas that we are now preparing to test at the regional level to say, what's the set of half a dozen or so things that we think would really add up to change at a regional level and start to mitigate some of those drivers of low value. So things like reversing the cost flow gradient, it's very common in our system that if you can't get in to see your primary care physician, well, you automatically go to the next most expensive place, which might be the emergency room. There must be designs, however, that allow you not to have to go to the most expensive next alternative. So you could find less expensive options when you run into a bottleneck somewhere in the system. Reclaiming wasted hospital capacity. We've got loads of capacity that's not fully utilized for a variety of reasons. We're learning quite a bit from some of our international colleagues about how we might address patient goals at the least total cost. And I won't go through all of these, but this is relatively leading edge work for us that we think will take us into more regionally based work and more regionally based results. So I think that is about it for me. Yes, for more information, there are some links here to our website. There are some interesting and rather in-depth case studies. A couple of them were just released that were prepared by the Commonwealth Fund, and there's a link to that information. And there's a link to me. So if you have questions or would want to learn more, I'm happy to hear from you. So with that, thank you so much. And I guess we'll turn it over to Ellie and let you pick it up from here.
Thanks so much, Carol. I think we're having a little bit of a technical difficulty to make Ellie the presenter.
If you'd like, I could advance the slides. I mean, until you figure out how to switch it off from me being the one controlling the.
Oh, there we are. Yeah, that would be great. I'm not sure what happened.
Okay. Yeah, I'm looking at mine, and it doesn't seem that I can reassign, but I can certainly, if you tell me when to advance the slides, I'll just do it for you.
I will, Carol. This is Ellie Whitman, and Dr. Barbara Powell will be chiming in as well, and we really want to thank Karen and CHCF for the invitation to join Carol Beasley to talk about HIP's experience as part of the IHI Triple Aim prototyping initiative. First, I'll start with a disclaimer. We're new converts to this. It will be a year that we've been participating since September, and so at this point, our aims and goals match the Triple Aim, but our run charts and metrics are still in development, and we look forward in future years to having the kind of outcomes that you can see from Bellin and Genesis and CareOrg and the other Triple Aim members. So from the Health Improvement Partnership, we feel very fortunate to have this opportunity to participate with IHI and the other Triple Aim sites, and we really appreciate the support of Carol and Dr. John Whittington, who actually visited us in Santa Cruz, and the excellent IHI staff. And it's exemplified now by Carol. If you would move to the next slide. So Dr. Powell and I were asked to answer 3 questions today. First, to give you a brief background on the Health Improvement Partnership and who's involved in that in Santa Cruz County, and why HIP decided that the Triple Aim was a good fit for our collaborative and our quality improvement work. And I see that I can now present, and I'll talk those 2 questions, and then Barbara will address the question on how already in less than a year we see that our quality improvement initiatives are different with Triple Aim, and we're going to specifically talk about our primary case study, which is a Health Navigator pilot for our subpopulation, which is uninsured adults hospitalized at any of the hospitals in the county. So, who is involved in the Health Improvement Partnership in Santa Cruz County? Well, our answer starts, this is a photo from our November 2009 annual board meeting. I know many of you will recognize faces in this photo and will recognize that this photo is the healthcare leadership in Santa Cruz County. It includes the public sector, it includes the private hospitals, the physician group, our Medi-Cal managed care organization, and it includes the safety net clinics. HIP actually was organized in 2004 for the purpose, first of all, of sharing information among the different sectors, public, private, safety net, and building relationships between those sectors. But from the very beginning, it was very clear that HIP also needed not to just share information, but also to find common ground and take action. And in this initial mission statement, which you see here, we have triple aims. They're a little different, but they were to expand access to care, to build a stronger system of care, and to improve our outcomes for all residents. So that's what we set in the very beginning, and this next slide really shows a outline of our organizational chart. We're really a collaborative of two coalitions. We include on the right the Safety Net Clinic Coalition, which includes the community clinics, the county clinics, also includes county mental health. We have a community dental clinic provider, diabetes education center, student health, our community college student health is definitely a safety net provider for many uninsured adults, young adults. And they're part of our Safety Net Clinic Coalition, which meets on a regular basis and really does quality improvement work within the safety net and within this coalition. On the left is the HIP Council, which we call HIP-C, which is a nice name, and it meets every month regularly on the second Thursday of the month at 7:30 in the morning. And these meetings, which are extremely well intended, include the hospitals, the physician groups, the medical society, our Medi-Cal health plan, the county health department. We have two foundations and outreach coalition. And then representatives of Safety Net Clinic also attend that HIP Council meeting. And this is where the cross-sector work, this is where the relationship between the safety net and the private hospitals, the county, and other plans, this is where that work happens. So the hallmark has been, despite the fragmentation and competition within our healthcare system in our county, how can we find common ground initiatives and common ground things that will raise all boats and that we can all work on together? And I guess it's no longer surprising that there's really a lot, in fact too much, to do in terms of common ground initiatives that we've taken on over the last 6 years. And this is a long list. It is actually only kind of a sample. We do much of our work in collaboration with other groups, not just within our healthcare coalition. So I really invite you to look at our website and get more information and detail about this list of common ground initiatives that we've worked on. I do want to talk about the two that are highlighted here because they really lead to the work that we're doing with AAA and the Health Navigator. So the first one is the Safety Net Hospitalist work. This was again identified as a common ground issue in the initial years of the Health Improvement Partnership, that the issue around care of the safety net patient when they're in the hospital and reducing their length of stay was a common concern and issue for the clinics, for the hospitals, and also for the Medi-Cal health plan and how to make that care in the hospital more effective and decrease length of stay. HIP had some money to hire a consultant to come in and do a feasibility study of a hospitalist program for Dominican Hospital to specifically focus on the safety net patients, and that was in 2005. And we have common ground does not mean fast track. So it took 2 years of discussion around this, and we come up with what is a remarkable hospitalist program, which is jointly staffed by the two competing medical foundations, and it was launched at Dominican Hospital in February 2007. So kind of having that in place opened up a whole another opportunity in terms of a common ground issue, because now it was the common ground issue became how to make sure that the care of the patient in the hospital was carried through and that there was a good handoff to the safety net clinics when the patient was discharged from the hospital. And right away we discovered that most safety net patients don't have a place to be handed off to. They don't have a medical home or primary care. And if they are members of our Medi-Cal Managed Care organization, they have a PCP. But those who are uninsured in particular do not have a regular source of health care. That's why they're going to the emergency department, and often that's why they're ending up in the hospital. And then the other thing we recognized is we needed to have better communication so that the safety net clinics, whether it was a known patient or not, would actually have information about what happened in the hospital so they could really provide effective follow-up. So that led to the Hospitalist Linking Project, and that was actually a project that was funded by CHCF and was to really take us to how to do that. So the outcomes on this project have been really quite spectacular. We went from 81% of our safety net patients having no PCP indicated on the record to 18%. Excuse me, that's for the uninsured. For all safety net patients, we started out at 43 and went to 8%. And once we did that, we were able also then to have electronically have those discharge summaries go to the clinics. But we found, so then the next finding was that, oh my goodness, we now have this information flow. We're linking patients on the records. But when Dr. Powell went in and did a chart audit of the community clinics, we found that patients weren't coming to the clinics, and that only 35% were actually coming in that first month to get follow-up care. And we realized that we had a new common ground opportunity, which was to create a health navigator for the uninsured to help make that transition and to try to, what we thought at the time was to convince patients to the importance of that follow-up care and why they should do that. So at the same time, we had discovered IHI work in AAA, and we knew we had some staff, and we had staff and some stakeholders who would be really enthusiastically endorse these concepts in terms of system change, in terms of bringing population health and disparities to the table. And but for everyone, it was a common ground to let's try the AAA project and joining AAA in order to see whether having this kind of framework and these kind of metrics will make this project more effective at really decreasing the cost of care for the uninsured and improving the health of that population. So I'm now going to turn it over to Barbara, who will really talk to you about what we've been doing in our Health Navigator pilot.
So as Ellie just mentioned, about the same time we brought up our Health Navigator pilot, we joined AAA. And we thought it was a good project with which to trial the AAA framework. And I'd like to share with you how that has turned out for us. The Health Navigator project did come about because we found that even though we had the foundations for good care transition, inpatient to outpatient, we had a doctor identified for the patient to go to, clinical information was being transferred in a timely way, 65% of the patients were still lost to care. So our premise was that providing a human bridge from hospital to home or hospital to outpatient care would be an effective way to make that care transition successful in the first critical days and weeks after discharge. And hopefully would be one way to decrease the rehospitalizations and emergency room visits, which are pretty high in our patient population locally who are uninsured. Our Health Navigator meets the patient in the hospital and follows the patient for 30 to 60 days after discharge until the handoff to outpatient services is complete. What's interesting about our current program is that the Health Navigator is not a clinical person. She actually has a master's in education, and that's been quite useful for us because, as you can see from the slide, she takes a very holistic approach to the patient. A lot of what she does is teaching the patient how to use primary care services, how to connect to services, communicate with the family about patient needs, listen to them vent when they're tired of having this person sleep on their couch, and also promote the patient's confidence in managing their own health care. Importantly, when the patient is readmitted to the hospital, she also interviews the patient to find out what went wrong so we can learn more about how to improve the system. This slide shows you our project metrics. As in our traditional QI approach, we have identified pilot measures for our project, and you can see them in the center column. We have metrics in each of the 3 AAA domains: population health, experience of care, and reducing costs. Pilot measures are focusing on small tests of change that are pertinent to the project, and the denominator for the measures are uninsured hospitalized patients. What's been different now that we are participating in AAA is that our team is also beginning to gather consensus from our health improvement partners membership about community-wide measures that would be long-term and that we will periodically assess to determine how we're doing as a region in meeting our care delivery goals. I'm not going to spend time on going over each of these metrics, but if you have questions about any of them, we can review them in the question and answer period. In Carol's presentation, she mentioned how important it is and how valuable it can be to learn from an individual case. And for us, paying attention to our patient's experience has been richly informative. This is a synopsis of Dale. Dale is actually our very first navigated patient. And we learned a lot about our healthcare system and when we followed his transition from inpatient to the outpatient world. So these are some of the things that we learned. First, we learned that the hospital was unaware that the county was taking furlough days. So that means that the county is closed periodically, both the pharmacy and the clinic on Fridays. Dale, of course, was discharged Thursday afternoon, and he was discharged without enough ostomy supplies or medications to last until the following Monday. The second thing we learned is that home health was not accepting any charity care cases, and that was difficult because Dale was very all I can think of is saying freaked out about taking care of his colostomy and really needed additional support to be able to manage his own care. The third thing that we learned, and this is important when you think back that we're having a 65% no-show rate for follow-up, the third thing we learned is that the clinic had implemented a $58 per visit charge for uninsured patients until their application for county assistance was completed. and that approval process can take weeks. So much of the barrier to follow-up care actually relates to the financial burden of having to pay $58 per visit. And no wonder we have such a low show rate for follow-up in our uninsured patients. Our Health Navigator was able to obtain medications and supplies through Dale by Thursday at 5 p.m., and our HIP staff has been able to speak with the county leadership and get the $58 fee waived for patients who are navigated. So with the Health Navigator assistance, we're happy to report that Dale has made it through not only the first weekend, but the first 90 days until his colostomy was closed without having to be readmitted or go to the emergency room. We've now completed our first quarter of the pilot, and we intentionally started slow because we know with each patient we are learning so much that we want to incorporate into our project design. We've had 10 patients so far. Their stories are very different ages, different backgrounds, different cultures, but their needs have all been fairly similar, as you see listed up on the slide. And thinking about our experience to date, I keep thinking back to a phone conversation that we had. It was one of the IHI international calls concerning care of psychosocially complex patients. We spent an entire hour talking about how to change the behavior of patients who are psychosocially complex so that they can get better care. And at the end of the hour, our Sweden colleague mused that, it's really not the complexity of the patient that creates the biggest barrier to care. It's the complexity of our system of care. And that is what we are experiencing over and over as we look at our navigated patients. To quote one of our local docs, Dr. Larry D. Cataldi, traditional case management focuses on making the patient comply with the system. With our new Health Navigator program, we're actually putting that concept on its head and trying to make the system comply with the patient. So in summary, how is our current initiative different than prior initiatives now that we are participating in AAA? Well, first, we are much more patient-centered, and that strong focus on patient care has just been richly valuable to us. Secondly, we feel well connected to a broad learning community that is rich in resources. For example, I had a question about one of our metrics and sent an email out to our AAA teams across the country, and within 24 hours, I got 9 really great in-depth responses with literature reviews and expert opinion. I couldn't have duplicated that research without the AAA community network. We've already talked about how helpful it is to be part of AAA in developing not only project metrics, but metrics that can be used community-wide. And lastly, AAA has enabled us to up our game in collaborative management of our QI initiatives that cross sectors. In fact, the AAA framework, the thinking about simultaneously thinking about population health, improving the patient experience, and reducing the cost of per capita care, that thinking is beginning to permeate our community and become part of our local culture. So in sum, we feel that AAA hopefully will be part of who we are as we go forward.
Thanks so much, Barb. Thanks so much, Barbara, Ellie, and Carol. I think due to the number of participants, we can have Q&A if you send your questions through the chat function, or if you could raise your hand, and I will unmute your line, and you can ask your question directly to our presenters. So, Alan, let me unmute your line, and you can ask your question.
Can you hear me?
Yes.
Oh, good. I got to spend a couple days last week up at Care Oregon, my home away from home. And David Labby brought up a very interesting issue that I wanted clarification on, if possible. Carol may be the one. When in the Triple Aim, when we talk about population health, David said that most of the QI measures that we are currently using, such as process measures or even outcome measures, are considered individual experience of care measures rather than population health measures, and that the population health was more, kind of on a public health level rather than on a medical care level. I had trouble understanding that, so I'd love some clarification.
Yeah, this is Carol. I'm not certain exactly what he was saying, but if we were to go back to the set of measures that right now for most are kind of aspirational. In fact, I don't know if it's possible to give me the ball again and I can just go back to that slide. But we're talking about things like, rolled up health or functional status. Yeah, thanks. I'll just get to the right slide here. Where did it go? Slide number. Okay. So yes, these do tend to be, or some of them are definitely public health type measures. So functional status, often that's coming from someplace like the CDC, or there are other options for measurement in other countries. In the UK, they have a pretty broad-based survey that they do of just basic self-assessed health status, which is honestly pretty good. It doesn't take an expert to tell you if you're feeling well or feeling not so well. I think that we're seeing some progress. Some of the sites, Bellin has done this, Genesis has done this, and I think we're seeing some interesting experimentation on really we're encouraging individuals to engage in health risk assessment instruments, to fill out a health risk assessment, and there's loads of these things around. And then starting to roll those up. And there's some interesting work that we've been introduced to by the folks at Genesis going on at the University of Michigan by a guy named Dee Eddington, who has done some work showing what the benefits are of at a population level of stabilizing risk. In fact, one of our partners at Genesis says that, she thinks we've been giving the wrong message all these years. We should, stop harping on people to lose weight and just tell them to stop gaining weight, because at a population level that would make a huge, huge difference if we could stabilize risk. So yes, you're right. A lot of these do shade into public health measures, but I think that part of our challenge is to pull these measure sets together in ways that are useful. So I guess referring to another piece of work that's been really informative to us, you might think of going and looking at some of the county health rankings that were recently put out with support from the Robert Wood Johnson Foundation. It was a team at University of Wisconsin that pulled this information together to try and compile information from a variety of sources, including public health sources, about population health. So I think that where it becomes a challenge is a lot of these population health measures tend to be more geographic. For a lot of the Triple Aim sites, they're not working yet on geographically defined populations. They're working on some subset of a population that they have a particular responsibility or relationship to. So I think that for those cases, we're probably going to find that building up from health risk appraisals may be the more practical way to go. I don't know if I've answered your question. You could.
Carol, let me ask one more question, if I may. In the quality metric world of California, there's a lot of focus on both process and outcome measures, either at a practice level, an individual physician level at times, which I think is generally inappropriate, and then most importantly at a medical group level. Mm-hmm. David implied that these would be considered patient experience measures because they're the sum of individual patients' experiences. And versus a population measure such as the D5 measure in Minnesota, for instance, which is looking at the measure of population health from a diabetic perspective across a large number of people. I'm confused, I guess, and I don't know how to seek clarity in this because I do see clarity in it.
Well, I think, if you're rolling up a bunch of stuff like, whether you're giving optimal diabetes care or whether you're doing, if you're sort of driving it from the clinical side, I would agree with David that, these are probably more measures of experience than they are measures of health. But to give you an example from the UK, one of our partners there, every year on each person's birthday, they get a card or they get a call checking in to say, how are you doing? What's your level of health? What's your full self-reported level of health? And they use that as a way to track what's going on from a health standpoint because that, My Health Today, just to personalize it for a moment, has relatively little to do with my health care because I don't get a lot of health care. And the conditions, I manage some chronic conditions myself. I have hypertension and I have asthma. So most of I manage those on a day-to-day basis. My doctor has very little to do with it. So if you called me up and said, how's your state of health, that would reflect in part the medical care that I get periodically, but it would also very much reflect those other determinants of health. It would very much reflect my health behaviors. It might incorporate something about my social circumstances and my ability to manage, my own chronic conditions in an effective way. So I think that there are some complexities about the measures, and I think it can be challenging to untangle the patient experience from the population health. But measures, I think, self-reported health status is not a bad way to go because that will include not just the person's health care, but also their behaviors and the other determinants.
Okay, now that actually helps a lot. Thank you.
Yeah, you're welcome.
Thank you, Alan and Carol. And Carol, there's another question that we had through the chat function. The person asked, do you have an example on remote patient monitoring affecting triple aim?
Oh gosh, let me think about this. Actually, we have an example again in the UK about how they've been using technology along with some other things for something that they call the virtual ward. So their ward would be like a patient unit. And they're doing some amazing work in one of the primary care trusts, particularly for older, frailer individuals for whom a hospital visit itself becomes a stressor, actually puts them at greater risk. So they've organized some really innovative ways to respond, for instance, to an older person falling in their home in a way that allows them to provide services, some of them technologically based and some of them more personal, people that can come to the home to provide support, but ways to avoid the need for a hospitalization and provide a suite of services, including some technologically based ones, to take care of that person in their home surroundings, where they live, where their neighbors and their children are nearby, and to avoid the expense and the disruption and honestly the risk of putting someone into the hospital. So yes, we are seeing the incorporation of remote patient monitoring into some of these strategies, and I think that the sort of using a triple aim framing might be a pretty useful way to figure out when remote monitoring or other kinds of technological options would be really helpful to get to the aims that you have.
Thanks, Carol. Are there other questions for Ellie, Barbara, or Carol? Let's see. Kathy Grant, I will unmute you. So, yes. Kathy, you're on.
Thank you. Do you believe that the individuals who are receiving these communications requesting how is your state of health or what is your level of health understand what you're asking them? Do you think that it might be better to ask them the question in a more in a more culturally or linguistically better way so that they would understand the detail that they're supposed to put down? Because that's the way we would or converse about a person's health. But I don't think that they look at it that way or that they understand.
So is there a way that if you wanted to get a quick snapshot from talking to someone of how they saw their own health, what might you ask them? Is there a way that you would go about that?
I would not be the one to ask, but I would refer you to Michael Villari. And Michael Villari is with the Institute of Healthcare Advancement, and they do address working with individuals with a more culturally and linguistically specific way that would be easier.
Yeah, so that sounds interesting, and I'll certainly look that up. I think, what we've seen on this, there may be some depth and some additional sophistication that you could bring to how you ask the question. But I think that what we've seen is that self-assessed health status actually tracks pretty well with things like ED use or things like hospitalization. When the people that say, I don't think my health is very good, typically are, in fact, the people that come to need greater amounts of healthcare services. So there's some reason to think that people know what they're talking about when you ask them how they're doing. But there may be some very sophisticated ways of asking that question that take into account different kinds of cultural ways of communicating, culturally appropriate ways of communicating.
And I think you might get a higher percentage of responses if the questions were asked on the level of the people that you're addressing.
Yeah, that's great. I'll take a look at that source material. Sounds wonderful.
Thank you.
We have time for one more question. If anybody wants to raise their hand or send a question through the chat function. I have a question for Ellie and Barbara, and I think that the initial results from the pilot of the Patient Navigator program are great. I was wondering, what has it been like to try and address some of the kind of gaps that you found in the care for patients like Dale, and how, in addition to having a Patient Navigator, what has been changed to try and address, for example, like kind of connecting patients to resources like housing and transportation? Are you trying to build something into the system of patient discharge based on what you've unearthed through the Patient Navigator system?
One thing we've learned is that it's been useful to have the Navigator focus on the individual patient's needs. And at the same time, to have the health improvement staff really focus more on the systems changes that need to happen to prevent the issue from recurring over and over and over again. And our Health Navigator is closely connected with our Homeless Persons Health Project, and they've been existing in the community for decades and are well connected to community services for transportation, connection to substance abuse treatment programs, and housing. And so our Navigator meets with the Homeless Persons Health Project on a weekly basis, reviews her cases, and they've been invaluable in helping her know how to connect that patient to services. So she's really serving as a bridge to many services that already exist in our community.
It sounds like there's a great need for the Patient Navigator. So we have one more question from Nisha. Nisha, you are unmuted and can ask your question.
Hi. In terms of the virtual world that you just explained, is there a link in terms of what technologies that they use?
I think that most of it is not highly technology-based. I think they use technology in an adjunctive way. What I would be happy to do, we actually had a presentation on this in one of our Triple AIM calls, and we record those calls. So I would be happy to work with Karen and make that link available to all of you that might want to listen to it and see, hear a fuller account of how they integrated the services that they provided. But I don't believe, my recollection of it is that they were not leading so much with the technology. What they were leading with was very similar to what Ellie and Barbara have presented. They're leading with the needs of the patient. And they're leading with, what could be done in a very simple way to evaluate someone who tripped over their cat, in their home, and they fell, and they're a little shook up, but they may not necessarily require hospitalization, and how can we provide them support without, putting them into an environment that for an older person is actually quite hazardous. So they're not, the technology is sort of adjunctive, not really the core aspect of the intervention. But I would be happy to work with Karen to make that recording. It's a WebEx recording, so you could hear the fuller account of it, and we can certainly make that available.
Great. Thank you very much.
You're welcome.
Thank you all for joining. We're at the bottom of the hour, and thank you to our presenters, Carol Beasley, Ellie Littman, and Dr. Barbara Paula. We will send the recording and PDF of the slides later today, as well as the link to the Triple AIM WebEx recording that Carol just mentioned. Feel free to contact me or Carol, Ellie, or Barbara directly if you have additional questions. Thank you.